Sure, I got that.
Have you been, I guess one question, it's like, as we're chatting through all this, it's like there's lots of options for HRT, but have you been getting questions from your patients around like what peptides to use during perimenopause or things
Oh, that's a
like those kinds
huge
of things
one.
to be
That's a
considering?
huge one. Yep,
Yeah.
yep, yep. So not just the
Yeah.
hormones, but peptides are more and more. People are starting to hear about them more and
Yes.
understanding which ones are good for which and what. And
Yeah.
so layering them in though, and that's kind of
Hmm.
what we're talking about today. It's like
Yeah, that's great.
how do you layer it in?
I know because it's like there's so many, and it's like what should I take? Do I need to be doing testing first? Where should I be getting them from? How do they interact with
Oh,
other things that
yes,
I'm
yes.
on?
That's a big one,
Yeah.
because there are so many people now, that are saying, here, come and buy our stuff. And you really just have to be careful where things are being sourced.
Yeah. Yeah, for sure.
Um,
Yeah, I think that's one of the big questions we've been getting from our clinics is
mhm.
where to source them from, what the difference is between getting them from 503A versus 503B pharmacies, what's the difference
Mhm.
with research grade, how much risk is there, all of
Exactly,
those things.
exactly,
Yeah.
exactly. And of course, all of the reps are going to tell you it's fine, don't worry about it. But yeah, no, they
Yeah.
are not all the same.
No, no, and it's very tricky too because it's like there's no standardized testing for a lot of it, and also what might work for you doesn't work for somebody else. Like I have one friend loves Motzi, swears by it, it's favorite thing, and then I have two other friends who tried it and they had horrible reactions to
Oh,
it. And it's like also when you're
we're all
kind of going
different.
on and like getting it yourself and figuring out
Hmm.
those things, it's like it's hard to know what's, I think, normal or not normal or what effects you should be getting from these things if you're just kind of
Exactly.
biohacking it on your own.
Exactly.
Yeah.
Yeah.
I'm a big fan though. I'm more comfortable using myself as a guinea pig than
Oh, I
other
know, right? Right. I mean,
people.
how do you know if you don't try it on yourself first?
Well, too, it's like it's also you try something, it's like then you can actually speak from personal experience. Like I had
Exactly.
developed like really bad acid reflux. I had horrible GERD, and I was on like all this prescription medication, and it was just making it worse. And then I was one of the podcasts I was listening to was talking about BPC and gut health. So I started taking that actually orally. Within 2 weeks, all of my symptoms were gone, and it hasn't come back.
It's so crazy. Well,
Yeah.
I mean, plus, I mean, that's working towards what's actually going on, as opposed to a
Yeah.
lot of the medications are trying to tamp down
Exactly. It's just treating
the
the
acid.
reaction your
Right.
body's
Yeah.
having
No. Yeah.
versus actually solving what the problem is. Yeah, for sure.
Amen. Amen.
We want that. Yeah.
Oh boy.
All right. Well, why don't we go on ahead and dive in and get
Okay.
started?
All right.
Well, it's great having you here. I'm Katya. I'm one of the founders at MedBio. We are very excited to have Dr. Susan back. This is session 3 on perimenopause. Um, I'll let you take over.
All right. So we've been having some wonderful times the last couple of weeks, with really diagnosing and understanding what things are. But to this day, we're going to start looking at how do we actually start treating and working with our patients and with our clients, because it's not all about using the kitchen sink. So we're going to start with a really quick poll, and we'll start with that. So, what is your bias towards intervention? We'll see if that'll come up with Katya. There we go. So, when a perimenopausal patient is symptomatic and motivated, okay, she's got the symptoms and she wants to do something about it, your instinct is most often to number one, start hormones early to stabilize symptoms, um, add multiple supports all at once to cover all the bases because you don't want to miss anything. address lifestyle and supplements simultaneously, start with 1 to 2 foundational priorities and reassess, or it depends and I'm often unsure. So those are the five, the 5 questions, the 5 answers that you could have. Someone's in your office, they've got the symptoms, they're ready to go. So what are you going to do? What is your go-to response? Just do it all, kind of do one thing or two at a time. What do you want to do? And so just think about that as we're going through the rest of this session. I'm going to end our poll now. Okay, excellent. So the whole thing is that the order of how we approach these things, and that's why this whole session is about how do we actually determine what order we're going to do things, especially in high impact women. Why? Because they're coming to you, they are, they're busy, they feel that they don't have the time to stop and do things. They want their results yesterday. They want you to understand what's going on to them. And usually by the time you're seeing them, they've seen more than 1 or 2, sometimes even more than that, other healthcare providers who haven't been able to give them the answers that they want. So they don't have that recovery capacity. And if you keep throwing things at them, you can actually destabilize whatever little bit of regulation they have left. And so that's why we're going to be talking about sequencing today. And we're going to actually practice some of that sequencing, because it will then reduce the likelihood that they will have a volatile reaction. Also, that they'll just drop out because if you make them uncomfortable enough, if they're struggling and they're already struggling, they come to see you for relief and you make things worse, they're out, they're gone. Okay. So we want to make sure. And we look at these things and what are they often doing? We may be putting them back in really hard workouts before that. You look at their sleep. You might throw medications at them before you look at actually what they're eating. And one of the big ones that we see a lot, because they're coming to us with hormone issues, is they'll come in and we just throw hormones at them without understanding what else is going on in their life. Okay, that's a big one. So what is our goal? We really want to be able to restore regulation first. Bring the fires, start putting out the fires first before we start layering any optimization. So the core rule, restoration before optimization, okay? And that's why the sequence matters so much more than what we do. And we want to start at the base. The other big thing is that we only go to the next level when their physiology is stable. And this is where you're going to need to be strong because, as I mentioned, these are women, they're high powered, they're used to getting their own way, they're used to running things their own way. That's why how they got to where they are. And they may not want to take things in a stepwise manner. But you will learn that if you throw everything, if you throw that whole kitchen sink at one time, they will not do well. Okay. And then if for whatever reason, even if it's not, something that you did, but if for some reason, maybe they've got some extra stressors that they didn't before, if they start to regress, if they start to have issues, you want to take yourself a step back. So if you've taken a specific treatment or added something and they're not doing well, just take a step back and reassess everything. So there are really 3 phases, and this is what we're going to be going over today, and then we're going to practice a little bit later. Phase 1 is stabilization. And this, out of the 3, is probably going to be the hardest to not necessarily convince them. Well, yeah, to convince them that it's important. Really? So we're talking about getting the HPA axis and their circadian rhythm back the way it should be. Okay, that's phase 1. Once that's done, then we can go into phase 2, which is building that foundation. This is where we start getting the metabolism back in order, when we start getting that musculoskeletal strength back. And then phase three, which is where often a lot of us want to start, we want to start at optimization, throwing things at people. We want to make sure that that is really stage three, after the stabilization, after the foundation has been done. Okay. And what's the result? Now we have a clear sequencing pattern, fewer flares, because especially if you've ever dealt with women or anyone, any client or patient with an autoimmune condition, what happens if you throw too much at them at once? They start to flare. Well, that's just a very obvious reaction, but it can happen with anyone, not necessarily, an autoimmune flare, but they can have more rashes or more joint pain or more fatigue or whatever it might be. And then if you have fewer flares and they're seeing the results, guess what? They're going to stick with it. All right. So you're going to get that adherence that you're really looking for. So let's talk about phase one. That is stabilization. That is the ground floor, which is non-negotiable. Okay. You want to normalize their sleep and circadian rhythm, and you want to calm that HPA axis. So remember, if they are stressed, if their lives are, they're putting out fires all the time, then what are we starting to see? We're seeing that they have what we call neuroinflammation. Their brain is on fire. And if you remember from a session or so ago, that picture of the brain that just looked like it was all lit up, that's neuroinflammation. You take that and then you put that same feeling throughout the entire body, and they are just on high alert. We've got to be able to help them to tone all of that down, to tone the stressors down. How do we do that? Sleep. Starting with sleep, okay? 7 to 8 hours of a sleep window. I cannot stress this any more than is possible. And why is that? Well, because a lot of these women, and I was one of them myself, feel or felt that they could get through on just 5 or 6 hours of sleep a night. That is not the case, okay? Getting regular meals. Okay, a lot of women want to, they want to stay, lithe and slim. And I understand that. I was a professional ballet dancer for years and a plastic surgeon for many more. So I totally understand where that's coming from on both ends. But we need to also make sure that we're eating regular meals, daily movement, morning light, so important. If a lot of women will have such a great response just to getting up first thing in the morning and going outside and taking a deep breath of fresh air. Reduce the stimulants. That's the coffee, whatever else they're doing, the caffeine, whatever they might be doing as well to keep things going. And then learning how to modulate, not manage, modulate, reduce their stress. Okay. So for starters, what might we start looking at if they're not sleeping? And we've done all of we talked in an earlier session, we talked about sleep hygiene. So we know the cool room, the dark room, the no television, all of those things. Once we have all of those in place, if we're still struggling, then we might want to look at some of these. So CBT insomnia micro steps, teaching these women how to sleep. And it may sound silly, but if someone is struggling, they may not realize that the things that they are doing, the activities that they have, the patterns that they have may actually be keeping them from sleep. Breath and HRV work. And we're going to be talking about that, because yes, as we get older, our HRV, our heart rate variability tends to decrease. But if we are stressed, if we are on high alert, it will decrease faster. Okay, so we'll be way below where we should be if we are stressed. 20 to 30-minute daily walks, and especially right after a meal. There have been some wonderful studies that show that if you eat a meal And then right afterwards, get up and walk 10, 15 minutes. You get more benefit from that short walk than if you were to have walked longer periods at a different time. So getting that walk in, especially right after a meal, protein with every meal. All right. We're not doing the girl dinner thing. Okay. It may sound funny, it may be funny, may be very easy to kind of just grab whatever's around, but we all need that protein with every single meal, especially as we're going through perimenopause. And we'll see some other reasons why as well. And then, of course, hydration. We're going to be talking about the supplements a little bit later and which ones to use when. Okay. So, what do we want to avoid though? Don't, like I mentioned before, hit leaving those out, long fasts. Okay. Large deficits, and then throwing a million different supplements at them all at once. Okay. And before we get out of phase one, remember these are phases, phase one, phase two, phase three. What do we want to do in this first phase? We want to make sure that they are sleeping at least 6.5 hours most nights. Of course, if they're traveling, if something's going on, if they got some huge presentation they're preparing for, they may not. But on a regular basis, we want more than 6.5 hours of sleep each night. We want to make sure that they're not waking up in the middle of the night. Okay, yes, to go to the bathroom, that's one thing. They get up, they go, they come back, they go back to bed and go back to sleep. But if we're talking about, getting up at 2 and then not being able to go back to sleep until 3 or 4 on a routine basis, that's something different. And that's when we need to figure out what's going on. And that's why, as we had mentioned before, it's so important to ask our clients what is going on, when you're not sleeping. Is it that your mind is racing? Is it that you're hungry? Is it, whatever it might be, what is going on so that we can fix it? We want the HRV to be trending up, right? We don't want them 25. That's for a 75 or 75-year-old woman, right? We want it to be in the 50 and up range. And we want the resting heart rate down. So looking at those trends, it's not a static number, but looking at trends. Is the heart rate variability going up? Is the resting heart rate coming down? And then symptoms, very simple. Are the symptoms reduced? Okay. All right. And give it some time and explain to them that it will take time. All right. Now we've got phase one. We're all good there. We're going into phase two. What does that look like? This is where we're really starting to build that foundation. So first we wanted to stabilize, get them out of fight or flight syndrome, get them into a point where they are now literally stronger and more able to take on what we're going to hand them. So what are our goals here? We want to improve that glycemic control. So remember, if they're in a lot of stress, what is their glucose doing as well? It's like this, boom, 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 up and down, right? Because it's responding to the cortisol. We want to make sure they have that flexibility back. We want to start building lean muscle mass and that functional strength. Why? Better metabolism. Okay. We know that fat is very hormonally active and sometimes not, well, often not in a good way. Our muscle is essentially the opposite. Okay. It's going to protect us. Enhancing gut resilience and nutrient absorption. So it doesn't mean anything if we throw 10 supplements at somebody and their gut's a hot mess, and so they're not absorbing anything, and it's just gone, right? So we think we're doing something, but we're really not. So we need to make sure that they are the gut can handle it, and that is being absorbed properly. Look also into, one of the things is that we looked at is the caffeine, but also alcohol, on a routine basis. That can actually flip how well someone is absorbing those nutrients if they're drinking a lot, So we want to make sure how things are going. And then really just expand their overall capacity to recover. So, for instance, think about it. If you haven't been to the gym for a while, um, and you go in and you do some crazy workout, what do you feel like the next day, next couple of days? I mean, you could barely walk up the stairs and everything. However, once you're in the gym, once you're doing these things on a routine basis, you get to the point where you might be a little, a little sore or something, or feel like something really worked out for an hour or two, but it's not days. And that's one of the ways that you can actually tell how your recovery capacity is increasing. Okay. What are the priorities? Add that resistance training. A lot of times we're so, well, not us so much because we know better, right? But a lot of our patients are so focused on getting their cardio in, getting the bike ride in and getting the runs and everything, that they forget that as we get older, our muscles, we start to lose muscle mass. And if we don't consciously and deliberately work at that, then we start, when we're 70 and 80 years old, then we start seeing the sarcopenia that can be a problem. Okay. We want to make sure we're getting that fiber and the protein. We talked about that. And then that circadian consistency. And as I mentioned before, walking after meals. So, what does that look like? What are some other targeted interventions? So, we've got those baselines, right? And then specifically for the muscle and bones and everything and inflammation, we might think about creatine, the omega 3s. Okay. Very important to continue all throughout, just because they're there for inflammation. They're going to help with, with gut health. Same thing with vitamin D. One of the biggest uh, what do we call low levels of most people, many people in the world, are those vitamin D levels. We want to make sure that we have good levels. It's going to be great for our gut health, for inflammation, for our immune system. Vitamin D is critical. And even though I'm not saying it here, vitamin D and magnesium kind of go hand in hand. You want to make sure the two of them are both doing well. And then finally, if you do see that insulin resistance, you want to start thinking about something like inositol and or berberine. Inositol is also great for sleep. So, if they're not sleeping well, you might want to add that as well. And then finally, targeted probiotics and soluble fiber. And then finally, when do we go to the next level, right? So this is phase 2. When do we go? When we've got those consistent strength gains and stable energy. So we're not doing the afternoon I'm wiped kind of thing. We have that stable energy throughout the day. If they are using a continuous glucose monitor, which I do recommend for everyone, your patients and everything, at least for a couple of weeks, just to see how your body, how your unique body is responding to what's going into it, to what you're eating, but also how you're working out, how you're sleeping. And you just look at those numbers, and I guarantee it's eye-opening. You want to make sure also that you don't have that recovery debt after your training. Okay. And then remember, pull one lever at a time. Again, you don't want to, have them doing, all of these different levers all at once. And then you don't know if something works, or if it doesn't work, you don't know what it is. So do one, see what happens, and then go forward. And then finally, we're up to stage 3, which is optimization. And here we have our, we stabilize them. They're no longer flying off the handle. We got them that foundation. They're strong. They've got the energy. They've got everything, and they can now take what we're getting ready to give them. So now what do we want to do? We want to start optimizing their performance, right? We want to get them to that point, but we don't want them flipping back into volatility. So we don't want to push them too hard and too fast, because then everything just kind of unravels. So you want to look at how they're training. You want to layer on a stable base. You want to do skills, 1 to 2 a week, and you want to support their brain as well. So what are some of the key interventions that you can do? And, as soon as a lot of us think of perimenopause, what do we think of? Hormones, right? Hormone therapy, which is wonderful if they are stable and ready for it. or their thyroid. Those two work, amazingly together. So you want to make sure that you're taking care of stages 1 and 2 before you hop into 3. Now, I say all of this with, if you want to say, a grain of salt. Um, we know who we're working with, right? And there are going to be times when you may not get the 3 to 6 months to flip all of this around that you would like. And so learning how, if you have someone who's totally on board, that is absolutely the best way to do it. If they are not, then sometimes you've got to be able to stack carefully and quickly so that you're getting them some responses, some changes so that they'll stick with it, but not enough to kick them over the edge. And that's kind of a fine line. Sometimes you feel like you're walking on a tightrope. And then nutraceuticals, things like CoQ10, which I love for people who are, looking for that extra bit of energy. Peptides, things of that sort. You may, and again, you may or may not be adding these earlier depending on that particular person's unique physiology. But I just want you to think about it and be aware that when you are doing this, that you're doing it for a specific reason. Okay. So, what do we want to be aware of? We don't want to just look at labs and then just kind of give something to fix the labs and make the labs look good. Yes, do we want to test and not guess? Absolutely. However, we also don't want to say, okay, um, I need to be at this number for this person, and I'm going to do whatever it takes to get them to that number. No, you want to know, how are they responding? How do they feel? If they need their, if you have a woman and you have them on testosterone for whatever reason, what is the level that makes her feel good, have the libido that she wants, have the strength and vitality that she wants without her hair falling out and breaking out and feeling like she's going to punch somebody in the head. So you want to make sure that you're not looking at a specific number, but actually the person who is sitting in front of you. Test and retest, if you need to, okay? Without just chasing the numbers. Do it for a reason. And remember, as I said before, if they're not doing well, back them up a little bit and, stabilize again and then move forward again. This is the way that you'll keep people working with you successfully. Okay. Not only will they have the great results, but they'll stick with you because you're hearing what they're saying. Okay. So, what might the interventions be to how ready we are? So, let's look at this. Red flags. Okay. So if they have a mood risk, if they start having chest pain, of course, undiagnosed bleeding. What if you started, BHRT and all of a sudden now they're bleeding? What's going on? High blood pressure, suspected obstructive sleep apnea. These are things that need urgent evaluation. Okay. We're not going to just ignore those things. But when we're looking at the capacity screen in phase 1, what are we looking at? Sleeping less than 6.5 hours, that HRV down, the heart rate up, having a higher symptom burden. They're having more flashes, they're exhausted, their brain fog, all of those symptoms coming on. Those are the things that we want to look at in phase 1. Phase 2, we want to make sure that they're stable, their energy is stable, their sleep is stable, and that really just the basic nutrition and movement, they've got that down pat. And then finally, in stage 3, are they ready for performance? Now it's not just I can make it through the day, but I make it through the day and I'm ready to go for the night too. Okay, so we're looking at those things, increasing that tolerance. And remember, you don't want to go to the next stage until you have met that metric. And 2 weeks is kind of an arbitrary number, but it's not, you don't want it to be they did it today and then tomorrow they're going on to the next stage, right? You really want to make sure that they're solid in whatever phase they're in before you push them into the next phase. Okay. So, what are some of the safety considerations and contraindications? Because we got to think about this. Safety is not just not harming someone, but we want to make sure that they are ready for whatever we're about to give them, or whatever we're about to throw in their way. And so with BHRT, we want to make sure that we're avoiding if, these are some of the contraindications, of course, but if they do have an active estrogen sensitive cancer, are there going to be exceptions to the rule? Of course, but you would definitely want to be in touch with their oncologist, with their gynecologist, all of these things before you jump into BHRT. Active clotting disorders, active. Okay. You may have just heard about the newest changes in the recommendations for BHRT. So the black box warning has been removed for certain types of BHRT. And they were ones that we really don't use anymore, and we don't use them in younger women. So the worry about thromboembolism just from BHRT has been looked at and is kind of been pulled away. But with all of that being said, if someone does have active disease going on, you really want to say, maybe not right now. Of course, unexplained vaginal bleeding and severe liver disease. Cautions if they have migraines that are having a lot of auras or that uncontrolled high blood pressure. Thyroid. So you're like, well, what's thyroid issues got to do with perimenopause? Well, estrogen and thyroid can kind of work against each other sometimes, especially if you're giving them hormonal therapy. So you want to make sure that you're looking at the diagnosis of thyroid disease first. You want to avoid overtreating because, as I mentioned, the estrogen can kind of play with how your body responds to the thyroid medication that it's receiving, and then make sure you're following their bone and heart effects. And then nutraceutical concerns, because even things that come from plants, even medications that come from plants can be an issue, as we all know. Clearly, berberine is that can lower blood pressure, not blood pressure, blood sugar. And so if they're already taking medication for their blood sugar, it can drop it precipitously. So that's something you want to be aware of and let them know that this is a possibility. Okay. And a lot of people are more than happy to say, okay, well, let's kind of play with this and in conjunction with their physicians, let's play with this so that we can come down off the medication, and maybe alternate with some berberine. Okay. Black cohosh, rare hepatic issues, melatonin. Okay. If you're taking it too late or too much, 6 milligrams, 10 milligrams is way too much on a routine basis. Then they wake up in the morning and they're groggy. Ashwagandha, which is a miracle supplement, because it's like how does it know? Like it's a thermos. So with a thermos, you put cold water and it stays cold. You put hot water and it stays hot. So you say, how does it know? Same thing with ashwagandha. If they are hyper, it helps calm them down. If they need some boosting, it can help bring them up. So it's like, how does ashwagandha know what you really need? But the issue is that it can boost up the immune system. So if someone's already autoimmune or hyperthyroid, it can make that worse. So you want to really just kind of keep an eye on that. You don't want too much magnesium. And then, of course, we all remember from training with SSRIs and the MAO inhibitors, we want to make sure that we're careful when we're giving 5-HTP. So, and of course, if someone is pregnant, thinking about it, even in the wind, you want to make sure that you know what you're giving them and have spoken with their OB-GYN. Okay. So what are some of the sequencing errors that I see quite a bit, and how do we actually fix what we're doing there? So, number one, starting hormones before stabilizing sleep in the HPA axis. We've talked about this multiple times. The consequence, well, they may not be able to take it, right? They're not going to tolerate it well. What do we do? Do phase one first. Very simple. Before you start throwing hormones at someone, make sure that their body can actually assimilate it and use it in a way that is good. Number two, aggressive calorie deficit. They want to lose weight and they want to lose weight fast. So they're working out and they're not eating. And that's a horrible combination, especially in perimenopause. Muscle loss, cortisol is going to spike. And guess what? When they start eating again, what tends to happen? Boom, that weight comes back on and often comes on with a vengeance. What's the answer here? Of course, build the base first. Okay, protein and resistance training. They will see such a sustainable way of losing weight and looking good. So it's not just a matter of losing weight, because you can be flabby and be skinny. Well, the whole skinny fat thing. We don't want that either. We want to be toned. We want to be strong, and that we get through protein and resistance training. um, Coming in, doing their testing and giving them a bag full of supplements. And I have seen that. I have had people come in to me with bags of supplements that they've been taking. Don't. Okay. First of all, they really can't absorb all of those things. A lot of them are going to interact with each other, and it's hard. If you've ever done that yourself, maybe there's some of us who do take a lot of supplements every single day and have done it for a while, but most of it, it's just hard. Okay. So add one to two at a time, see how they respond, and then continue. And the other reason for that is if you give them a bag full and they have a bad reaction, why? What was it that had the bad reaction? Fasting. Okay. We know that their glycemic index is going to swing. They're going to be fatigued. We just want them to have regular meals. Okay. And then finally, we're just throwing medication at the thyroid without looking at other cofactors. You can actually flip them into either palpitations or anxiety. You want to make sure that you're fixing the cofactors, the things that they need, the iron, the selenium, protein. We've already talked about that. We want to make sure that we're looking at those first. And a lot of times, not always, but sometimes just by fixing those things, they start to change their thyroid status even without medication. Okay. So let's go over three. We have our three phenotypes. We have the executive, the elite athlete, and then the healthcare provider. So we're going to start with Ava. Ava is 47. She's a tech executive, and she's on the road about a third of the time. Okay, so she's on the road a lot. What does that mean for us? What is that telling us if she's on the road a lot? Okay. What are you thinking first? Well, she may not be sleeping well because she's not going to be at home. She's probably going to be dehydrated unless she is very, very religious about getting her fluid. And if you look, she's in this airport lounge with a cup of coffee, right? So she drinks a lot, 4 cups a day, 4+ cups a day, right? So she's not really hydrating, especially if she's drinking coffee. She's actually making herself more dehydrated. When she flies, that's going to increase that. She's got the stress of travel, period. So she's got a lot of things going on. Add that she's got hot flashes. She's not, as I mentioned, she's not sleeping well, and she crashes in the afternoon. 2 to 3 o'clock in the afternoon, she is flat unless she has that cup of coffee and some sugar along with it. So baseline, she is, mild insulin resistance and a high stress load. So baseline, she's sleeping 5.5 to 6 hours. Good enough? Her HRV is low. Okay. She's 25. For a 47-year-old, that's too low. Okay, that's like I mentioned, that's a 75-year-old woman. Caffeine 4 cups a day. Her resting heart rate is 74, which is trending upwards. It used to be in the 60s. Now it's in the 70s. And her diet is irregular. She's running through the airport. Sometimes she's eating, what is the little they're like little bagel things. I'm not going to say the brand name. That she's eating those, and sometimes she's eating a real meal. So very irregular timing wise and quality wise. So what might we think of here? What phase would you have her start in? Let's kind of just start with that. Phase 1, and this is where we can look at our sheet that we have. So our therapeutic layering plan, which phase does she start in? And if she is, we just looked at that, she's sleeping 5.5 to 6 hours, low HRV, and not eating well. So guess what? She's starting in stage 1. Okay. So what might that look like? She's going to start in 1. What are some of the things that we might want to do for her? She's not sleeping well. She's not eating well. What else might want to do in this first stage? Well, let's take a peek. So the cranial behavior therapy for insomnia, those micro little steps that we do first. How do you sleep? How do you get back to sleep? How do you do these things? And then a travel sleep kit. Have her have the earplugs and the mask here, and maybe even a little machine that makes sound so that she can sleep a little bit better. Whatever that might be, or whatever will help her to sleep better at night. Caffeine, cutting off it at noon, which can be hard, right? Especially if she's got that afternoon flop. So sometimes, if rather than just saying cold turkey, don't, maybe go to something like green tea or whatever else it might be, and then back her back a little bit slower. Getting light first thing in the morning. One sec. Okay. And protein at breakfast and getting that walk in. So this is one of the things that I share with a lot of people who travel a lot, because they're like, well, I'm at the mercy of whatever's in the airport or whatever. And the easiest thing to do is, first of all, just pack yourself some nuts. Doesn't take a lot of space. Nuts or some other kind of protein that you can carry along with you. All right, that's easy. The other thing is that once you get there, most hotels now have a little store, if you don't want to go out to a store, but a lot of them have a little store downstairs in the lobby where you can get, if you look hard enough, you can get some better protein snacks so that you've got those when the urge to have a snack or something comes up. And then remember having that 20 to 30-minute walk after the meal. Okay. It doesn't even have to be 30 minutes, 10, as I mentioned, 10 minutes right after a meal is more valuable than 30 minutes later on. And then magnesium glycinate will help with sleep. It will also help, if she's dehydrated and not drinking a lot of water, what also tends to happen when we're traveling a bit, we tend to get a little constipated, right? So that will help with that as well. And the omega-3s, decreasing that inflammation. When do we know we can move to the next stage? When we have at least 2 weeks of sleeping more than 6.5 hours, and we're seeing her HRV starting to trend up. Okay. And these things happen quickly, which is a good thing. When we're taking people through the right stages, they do heal very much quicker than we would often think that they would. Okay. So now what? What does her foundation look like? So that was her first month. Now what for the next next month or so? We're going to start adding resistance training in, and this is not hard. If she's traveling a bit, all she needs to do is take some bands with her. They fold up really flat. They don't weigh anything. It's not like she's carrying her weights with her. She's just carrying some resistance bands. She can do that in her hotel room first thing in the morning, before she does anything else. And then again, continuing to walk after meals. Now that she's eating a little bit better, she's not struggling because she's getting more hydration, we can start adding that fiber. If you remember from our earlier lesson, we want to be careful adding a lot of fiber really quickly, because if they haven't had or haven't been eating it before, it's going to make them bloated and then they're not going to like you. So you want to make sure that you are putting that in slowly and allowing them to equilibrate. Creatine and inositol, and then keep those sleep anchors strong. Like I mentioned, she's traveling a lot. She's in and out. Her hours are very irregular. So getting her to understand how important that is and to continue to sleep. And usually once you get past that first month or so of people sleeping more than they're used to, they start feeling so good that they start protecting their time. Once you get them past that first month or so, they are now like, talking about, this is the best thing ever for me. So, and then the gating criteria for this: when do we move to the next stage? When her strength and energy is stable, and we look at, if we had a glucose monitor, we're looking and making sure that her meals, her glucose post meals, have stabilized. Because before, with the insulin resistance, she would have a meal, it would spike, and then we all know if it spikes up, it's doing what? It's spiking back down again. So, and that's a horrible feeling for anyone who has felt that, the spike up and then the spike down. If you're aware of it, once you understand, like if you've had a glucose monitor on and you realize what that spike feels like, you never want to experience it again. Okay. And then what does our third phase look like? Our optimization. We're going to add the HIT now. Now we can add those, because now she's got the energy, she's got the stable base. We can talk about, is she a candidate for BHRT at this point? CoQ10 trial. And then what we want to do now is start adding some of the, and she probably was already wearing wearables, right? The watches, the Aura rings, the things of that sort. She's probably already had them. Otherwise, how would she know what her HRV was? But we want to really start following them closely now, so that if things start to slip, we can catch them quickly before she's way back, where she started. All right. So how much of that did you all get? Did you get the stabilization part, the foundation part, the optimization part? And that's it. It's 1, 2, 3. Really, really, really simple. Okay. So now Ava was all on board. She was really good. Now, what do we do now, though, with someone who feels like they can't make the changes we're talking about? And that's going to be our case 2 study, who is Maya, 44-year-old. She is a pro triathlete. So, that's biking, swimming, and running. Okay. And so she trains hard. She trains hard, and she's got an upcoming race. So she is like, I need it, but I don't have time to stop. So she's been in perimenopause for 18 months, almost a year and a half, right? Her issue, though, is that she came to you because she's, yeah, I know I'm in perimenopause. That's water over the bridge. What's important to me is that my training times are going down. I'm working harder and harder and harder, and my training times they're just getting worse and worse and worse. And I've got this race. I got to do something about it. Her cycle is 25 to 60 days. So we know from our very first class in perimenopause, she's in, just because of those irregular cycles, that alone is a definition. She's getting recurrent stress fractures. Okay. Ankles, because of the running, because of everything else. And little minor ones that are setting her back. And so she's really kind of, she's starting to get really frustrated. And she's got this, even though she rests, she's really exhausted all of the time. So what does she do? We know the main thing, she's got this major championship in 16 weeks, and she is not willing to say, she's not willing to stop. Okay. 16 weeks. What is that? 4 months. Okay. She is not willing to stop training because she's going to this no matter what. If she has to drag herself, she's going. So she's training 12 to 15 hours a week. Okay. She's fasting 16/8, and she's eating clean, really, really, really low carb because she's trying to cut a lot of fat. She wants to build up that muscle. She's taking an adaptogen stack, collagen, and vitamin D. So what are we thinking here? All right, now we're going to get some data. I'm going to give you a little bit more information, some labs and everything. So her thyroid, TSH of 3.8, which was trending upwards from 1.2. Her free T3 is 2.2. So normal, but just barely, really on the low end. Metabolically, she had on a glucose monitor. Her monitor is reading 55 to 62 in the middle of the night. Body composition, her fat is going down, her weight is stable. So even with all of this, so she's doing a lot of intermittent fasting, a lot of working out, and her weight's not really changing, which is a good thing, although her fat is decreasing. Her T-score is minus 1.8. So we know that we want to be within a standard deviation of 1. Okay, so 0, so either minus 1 to 1. She's minus 1.8, which is down from 0.5. So she had been fine. Now her bone density is decreasing. So we're keeping this in the back of our mind. Is that this why she is now developing these stress fractures where she wasn't before? Her hormones, her estradiol is erratic, perimenopause, 12 to 240, right? She's up and down all over the place. And her resting heart rate is up. She used to be 48. I mean, she's an elite athlete. Now it's 58, which is still better than most, but for her, that's not great. And her heart rate variability is down to 30%. So remember, that's a 75-year-old, not a 44-year-old. Okay. So the complexity here is this red S, the relative energy deficiency in sports. Is it perimenopause? Is it subclinical hypothyroidism? Well, I think we know it's probably all three of them, right? But can we treat all of them at the same time? Can we throw the supplements and the hormones and everything all at one time? Well, we're not going to, right? So, but what are some of the trade-offs that we have to look at? Her bone versus her performance, right? We're seeing that her bone density is decreasing, and this is she's actually putting her bone health at risk because of a lot of the things she's doing with her workouts. We also know that as her estrogen lowers or is variable, that affects bone health, right? That and testosterone. Estrogen and testosterone are both very important for bone health. So as both of these either decrease altogether or erratic, our bone health also has issues. Thyroid, the adaptogens that she's taking are probably masking the issue with her TSH and her free T3. The real fix, what she really needs is to have more calories at this point, which scares her because she's like, I'm doing all of this and I'm not losing any weight. So you want me to eat more? We'll talk about how we talk to our patients as well. And then the low carb that she's eating may be impacting this midnight waking and everything. So what do we want to do to reduce the harm? Well, first, we got to fuel her work. Okay. She's got to stop the fasting. And sometimes it's great for her right now in this stage. It's not. We want to swap the HIIT for heavy lifting, giving that bone the help that it needs to get stronger, and then prioritizing her sleep. So letting her sleep in a little bit, and getting the rest that she needs. So how do we actually negotiate? Remember, she told us she's not giving up that race. That's just it, right? So what you can say to her is, give me 2 weeks. Just give me two out of that. What did I say that was? 16. Give me two out of that 16 weeks to fix your floor. And if we do that, then everything else will stack on better. Okay. Maybe have her try adding a little bit of carbs at night, healthier ones. We're not talking about, cookies, but maybe a sweet potato, okay, along with her protein at night, to see if that helps her stabilize that blood sugar throughout the night. And then if she's going to train hard, she's got to recover even harder. And then finally, our third case is our healthcare provider. And she's got some things going on as well. So you can see she's an ER doc. And she does rotate shifts. So, because she works at a couple of different hospitals. Like if she were just at one hospital, it wouldn't be that big a deal, but she's got a couple of different hospitals going on. And so she's got different shifts. So, what are we seeing with her? She says, very unlike her, she's almost, she just finds herself yelling and just being just totally out of control. So these episodes of rage that are so much not like her. But on the opposite, on the flip side, she's also got brain fog. So she can't think as fast and as quickly as she would like to, and especially as someone who's in the emergency room needs to be able to. Unfortunately, despite everything she's doing, she's gained 25 pounds, which for her is, again, unthinkable. She's starting to have palpitations, and she has a migraine that's been increasing in frequency and severity. So, what are some of the data that we're seeing with her? Her insulin is 18, fasting insulin, remember? And if you remember again from our numbers, we want for it to be really optimal, we want it to be like 5. So by the time we're getting up to 18, what is this saying? It's that our body is pushing out insulin to bring our blood sugar down, but our body's not responding as well as we'd like it to. So if this continues and that keeps going up and up and up, eventually we're going to start seeing things like type 2 diabetes. And look at where her A1C is, 5.8 now, right? So we know that 5.7 and above is considered pre-diabetic. Her estrogen is 180, progesterone is 0.8. So she is now an ovulatory and estrogen dominant. Okay, so in comparison, estrogen to progesterone, she's got more. Okay. She has a sleep study that showed obstructive sleep apnea. And her regimen, her motto is do more, try harder. Never say never, never say stop. She's doing HIIT 3 times a week, 16-hour fast, very much like our other women, 4 espressos per shift. Okay, so she's drinking a lot of coffee and caffeine. And every night when she comes back, or Billy, whenever it is, she's using wine to decompress. All right. So what's making this even more complex? That shift work knocks out her HPA axis and the circadian rhythm. And the fact that she's going back and forth, sometimes it's late, sometimes it's early. It's a mess. And she knows better, but she doesn't, because what they say, to know and not to do is not to know. Well, that's Dr. Raina. Okay. So what do we think about with her, right? We know she's insulin resistant. Her cortisol, oh, I missed that. Her cortisol is flat. At this point, even though she's running like crazy here, her cortisol is just flat. So she's literally running on just pure adrenaline at this point. She's estrogen dominant, not sleeping well, and I just said insulin resistant. So where are we going to start with her? The dilemmas are, getting that phase one structurally, getting her sleeping properly is really going to be difficult. And this is how life is. And not everyone's going to come into us like our first patient, our first CEO, who said, okay, I'm good. I can do whatever you say and let's get started. No, most of them, or a lot of them, are going to come with these issues that make it difficult for them to even do the baseline stuff. Okay. We know that she's got this metabolic threat. She's not sleeping well because of the sleep apnea, the shift work, and she's insulin resistant. Okay. She's got the migraines with aura. So we want to be careful of adding the BHRT if she needs that. And we do know that, her cortisol is flat, but she's adding things that are stressing her out even more, stressing her body even more. So we want to be able to reduce the harms first if we can. Um, we can't we can't make phase one completely stable, and this is what's going to happen sometimes. We can't always have it the way we want, so we've got to figure out how do we make it the best that we possibly can. First thing, treat the OSA. Give her a CPAP or whatever she might need to help that sleep apnea, number one. Fuel the shift. Again, just like our runner, our triathlete, you want to stop the fasting. Okay. Give her more frequent protein to stabilize her blood sugar. And then finally, swap that intensity. Okay. That's one of the easiest things that helps quickly and makes our patients feel so much better, so much faster, is adding that resistance training, adding the weight training in. And remind them, because they're going to ask, am I going to get muscles like, Arnold Schwarzenegger? No, you're not. You're just not unless you take a whole lot of exogenous hormones. And even then, it's not easy. So the script that we're going to use for her this is now the expert. She knows. I mean, she knows pretty much everything that you're telling her. But, like I said, to know and not to do. So we want to talk about, we can't out supplement your cortisol curve. At this we can't make it better just by giving you supplements. You've got to change your lifestyle. You've got to change that foundation. So we've got to stabilize also the floor, the blood sugar, because your HPA acts as the cortisol, the adrenaline, that's all in the circadian rhythm. Those are all out of control at this point. So we've got to fix what we can so that you start to make those changes and getting better. All right. So let's go back over these phases again. What are the phase 1, 2, and 3? Okay, for her, for any of us, we want that sleep window. Okay, we want it to be long enough that they're getting the rest that they absolutely need. Breath work, adding for her 2 to 3 times a day. Okay, and that's something she can do on while she's in between patients. Sometimes you can even learn to do it while you're working with patients. It actually slows your heart rate down, probably even slows their heart rate down, your patients as well. Moving. Now, we've got this 7 to 10K steps. Maybe yes, maybe no. Maybe not in the beginning, okay? Really depends on what's going on with them and how their body is reacting. Remember, the timing is even more important than the length. So doing it right after meals, much more important than the fact that you're getting 10K steps in. Nutrition, regular meals, protein, and then alcohol, limit it to 1 to 2 a week. Okay. Foundation, increasing that resistance, protein with every meal, getting that gut health, and recovering. Putting those bedtime anchors, because remember, her schedule's flipping back and forth all over the place. So she's got to be able to make sure that when it's bedtime, it is bedtime, and that she goes to sleep. Okay, so getting those bedtime anchors really strong. And then how do you optimize for her? Training, build, peak, and deload. You can start adding, once she has stabilized and has that foundation, you can start adding the intensity. You can, as far as if she's traveling, travel proof routines. Remember our first person, we want to tell her, what do you bring along with you so that you're not at the mercy of whatever's in the airport. monitoring, have each one of them, each one of your phenotypes, have them have specific KPIs, key performance indicators, for what their health looks like to them. So is it their sleep? Is it their blood sugar? Is there their heart rate variability? Whatever it might be, make sure that they understand what it is and why they're tracking it. And then that helps to get them even more on board. Nutraceuticals, phase one, two, and three, same way. So phase one, you want to make sure they've got magnesium on board, especially if they're not sleeping, especially if they're constipated. And there are some different formulas for different issues, but magnesium glycinate is a wonderful across the board one to have. Glycine and L-theanine both tend to work very well and help with sleep at night. The omega-3s, that anti-inflammatory baseline. And then finally, the gentle adaptogens. Be careful of the ones that might, trigger thyroid issues if need be. Introduce one or two at a time. Not all of them at the same time, one or two at a time, and then increase as they are doing well. Okay. Phase two, start thinking things like creatine, vitamin D. I might actually even move that into phase one. I don't know. You can kind of play that one by ear, because often so many people are so low in vitamin D that it actually impacts a lot of their health as well. Inositol berberine for the blood pressure, but also, as I mentioned, inositol for sleep, and then probiotics and fiber. And then in phase three, to optimize, you're starting to add those things for body composition and extra mitochondrial support, nootropics, the peptides, the BHRT, and fine tuning with your thyroid. So you may have, even in phase one, you may have been on, or your patient may have been on thyroid support, but kind of really fine tuning, because remember, as I mentioned, if you get all of these other things straight, sometimes they don't need as much. So now you're fine tuning where they are. All right. And what about adjunctive therapies? When would you add them and why? So let's just kind of go through all of them. CBT insomnia. If they have that persistent insomnia and you've done all, like I mentioned, you've done all of the basic stuff, all of the sleep hygiene, all of that's doing really well, they're still struggling. If the nervous system needs some support, looking at HRV biofeedback, especially during phases one and two. You shouldn't still be needing to adjust their HRV if they're in the optimizing stage, right? That's what this is one and two. If they've got symptoms, vasomotor, acupuncture is wonderful. So, especially for hot flashes and reducing stress. One of the nicest things that patients can actually get into and see symptom relief. Getting that bright light, especially during the winter seasons when it's dark, you want to make sure that they're getting the light that they need. But even year round, as I mentioned before, getting that light first thing in the morning is wonderful. This is another life changer, structural issues. If they are having pain or dyspareunia or prolapse, urinary symptoms, pelvic floor PT is an amazing thing that can be added. OSA screening, you want to make sure that if they are suffering with sleep apnea, that you're working with it and treating it, because again, if they're not sleeping, or if they're not sleeping soundly and well, they're not going to do well long term. And then finally, when do we start adding in the BHRT? As I mentioned before, there may be, if something's way out of whack, you may need to start sooner. But optimally, if you have the options, you want to be able to do it after they are stabilized, okay? Because as I mentioned before, a lot of times when you fix the stress, when you fix the other things, a lot of these issues go away on their own, okay? Reduce overtreatment, improve the outcome. So do phase gate, make sure they're ready for the next stage before they move on. Test and retest if you need to. You don't always have to do this frequently, and it doesn't mean blood tests or whatever, but test how they're responding. Remember, we talked about the KPIs. How are they responding to what you're doing? Align the plan with what they can do. If they're already busy, they're getting ready for some huge merger, and you come up to them and tell them you've got to start, making meals, and no, it's not going to work. So look at what if are they getting ready to travel? What is their capacity? How do they feel about these changes? And then build in, if something's not working, and you've given it a good chance, they've given it a good try, then you need to reassess. Okay. Avoid making a lot of different changes all at once. Remember, I said they are going to be impatient. They're going to want you to fix them yesterday. Let them know that the best way for that to happen is for them to systematically move through these changes one at a time. Don't chase the perfect lab tests. Okay. Good is good. Good is good, especially if they feel great. Okay. So if they're feeling good and you're seeing them moving in the right direction, you don't have to chase a specific number. We talked about changing before they're stabilized. And if they're not doing well, a lot of us have so much invested in helping our patients and clients to feel better that sometimes when they're not responding well, or if they're actually going in the opposite direction, we're unwilling to really talk about it because we feel it's almost like we didn't do our job. So we want to make sure that we're not ignoring when they are struggling as well. And then you definitely don't want to just add just for the sake of adding. Okay. And think about it, with any particular person that you have coming in, what matters the most for them? Is it their sleep, their energy, their steps? Well, their strength, their glucose. Each one will be different. So you want to think about which one is the most important for that unique person sitting in front of you right now. So here are 4 things that you want to be able to do. Design for reality. Okay, like I said, these are busy women. You can't give them a 20-page protocol to do. It's not going to happen. Make it simple. 5 to 15-minute micro moves that they can do at their desk or on the road. Portable kits, hotel-friendly workouts. Make it so that they can do it. Every little success takes them one step closer to their final results. Teach them also about linking things, pair, like if they have a podcast that they love, link it with their walk, things of that sort, so that they can continue to build on what they're doing. This one is so important. Reduce friction. Now, you may say, you need to meal prep and that may not happen. But guess what? They can order meals in. They can order meal preps. And I have done that on days and weeks and times when I had no more capacity. There are companies that will make them their supplement stacks so that they don't have to sit there and pull them out. Yeah, we do have the little packets that they can make, but maybe they don't want to do that either. You can actually get them so that the whole pack is there. All they've got to do is just tear it and take one. Okay, make life easy for them so that it's not difficult to be compliant, and then link their motivation to their ROI. And again, these are high performers. They're used to feeling good when they're doing good. Excuse me. And so, have them understand what it is that is a win for them. Like our runner, with her increasing her HRV or decreasing her times, or whatever it might be, increasing her strength gains. Those are wins for her. So make sure that you're linking those goals so that they understand how these things might be going forward. And just as a practice, and you'll get a sheet. If not this week, yeah, I believe it is next week. Next session, we're gonna give you a form so that you can take yourself and your clients through these stages. Okay, you'll be able to put them out. So you'll be able to summarize the case and the drivers. What are the factors that are causing the issues that they're seeing? Is it the HbA, the metabolic, structural issues? You're going to be able to assign them in phases 1, 2, and 3. It's not really complicated. 1, stabilize. 2, foundation. 3, optimize. Then you can select the interventions, because now you can see how clearly it is. It's like when you see it in front of you, it just becomes so much more, it's easier, but it's so much more clear to actually intervene. And see how quickly they're going to go through things and just kind of set. Remember, you usually want at least a couple of weeks in one stage before you move into the next, just to make sure that it's not a fluke that they hit it one day or so. And then make sure that you built in ways to make it easier for them, ways to make it easier for them to stick to whatever their plan is. And remember, what are their gating metrics before they move on? Sleep, more than 6.5 hours, fewer waking. The HRV trending up for the HRV, trending down and stable for the resting heart rate. Energy, more than a 6 out of 10. I'd like to see more than a 7 out of 10, really. And even that's kind of on the low side. So yeah, would we love to see 10 out of 10? We definitely would. Will you often see that, especially in a high-powered woman who's got a lot on her plate? Probably not. So, and then finally, we want to see those symptoms reducing. And then, you're only going to advance after they've been meeting those statistics for at least a couple of weeks. And if for any reason they look like they're struggling, if they start getting more volatile, if Dr. Reyna starts yelling at people again, we want to move them back a stage and have them stabilize again before we move forward again. Okay. So what are our key takeaways for this lesson? Number 1, use a phased approach. Stabilize, foundation, optimize. Okay. Those 3 stages. And once you see them, you cannot unsee them. And it's so easy. Okay. Number 2, match the intervention to how ready they are. All right. Don't give them, extra hormones if they're only sleeping 3 hours a night. Okay. Make sure that the interventions are matching what they're ready for. Sequence before scale. Okay. And then finally, building them for these high impact women. Well, you want to make sure that you're reducing the friction, making it as easy as possible for them. And remembering a lot of them will travel and life gets hard when they're on the road. Okay. So you want to make sure that you're making it easier for them to stick to it and stick to it even when they're not at home. For Q&A, getting ready for our next session, what we're going to be doing is, if you'll bring, and actually you can send these in ahead of time, or you can bring them to the next session with you, but we want to know, what are the most challenging sequencing decisions that you encounter in your practice? What are you seeing frequently? Is it that they look like they need their BHRT before, whatever it might be? So we want to look at that. We want to see, how do you introduce those hormones without really destabilizing everything that you've done before? Okay. Is that possible? Obviously it's possible, but how do we actually do that? How do we travel proof? Okay. What are some of the tactics that you've seen that work, and which ones don't work when people are traveling? And then which KPIs do you use to track when or not to advance or regress people? Maybe it's not their HRV, maybe it's not their sleep. What do you follow on a routine basis? And what I would love to do is offer you an opportunity to bring a case. If you will, you can kind of send it to us ahead of time. I'm sure Katya will share the email and you can just send it to us and then we can go through a specific, maybe one or two cases that have been brought up that you're literally seeing in your own practices. Yeah, right. Cool.
Well, this has been great. Actually, one question for you. With HRV, I was working with somebody recently, and it's like everything seemed to be okay, with the exception of that metric. And so we went back and looked at, what it was on her Apple Watch, and it's like it's been consistently low for since she got it, like years ago. Like, are there people who just have lower HRV, or it's tough, right? Because it's like you can't see what it's been her entire life.
Her
But
entire life, exactly.
it's like, I mean, it's consistently between 20 and 30, and it's like in shape, active, eats well. Like all the other things seem okay,
Everything's okay.
except for that. And it's like concerningly low.
Look,
Yeah.
got it, got it. So, just so that we're kind of all on the same page with the HRV, what is like the time interval in between heartbeats. So, unlike it, because when I first started learning about it, it was like, well, how come a higher HRV is good, but AFib is bad? It's like, what is it? But it's two
Yeah.
different things. Anyway, yes, there are some people who just naturally have a lower one. And so that's
Hmm.
one of the cases where I would say, if and I do mean if everything, if she feels good, sleeps good,
Yeah.
eating well, I mean, if everything else is fine, I would just ignore it. You know
Okay.
what I'm saying? Yeah. Yeah.
Interesting.
Mm-hmm.
Yeah.
It's like that you can't get hung up on any one particular number, not
Right,
if
right, right.
everything
It's
else
more
is
just like
safe. Yeah.
holistically how
It's
are
a
things working.
holistic kind of thing. Yeah.
That's good to
Yeah.
know. Good to know.
Mm-hmm. Yeah.
Well, great. This was it's been great today. We'll get everything posted, and then we will be back on Thursday for the last session.
Last
And
one.
yeah, we'll send out a follow-up note if anyone has case studies they want to bring. That'd be great.
Perfect. Perfect. All
Perfect.
right.
All right. Well, have a good night, everybody.
Thank you.
Thank
Bye.
you. Bye.